Okay, perfect. Has there be a bell that rings or anything? We're okay. Okay. Hi, I'm Janene Holmberg, and I am a physical therapist who specializes in dizziness and balance at the Hearing and Balance Center, Intermountains Hearing and Balance Center, and it's an honor and a privilege to be with you today. I love interacting with patients. I love the wisdom that we can gain from each other, so it's an honor to be here. So just a little bit about me. So again, I am a physical therapist that's kind of specialized my practice for the last 30 years in dizziness. You know, some therapists do necks, backs, and I just do dizziness. And so it was kind of a niche practice, meaning almost nobody was doing it when I started. And I was brought to Intermountain 24 years ago to actually develop a dizziness and imbalance clinic, because dizziness and balance problems historically don't get managed very well in the healthcare system. So at this point, I've seen over 3,000 plus dizzy patients, and I lecture around the country and the world on dizziness that comes from a multitude of things. And so I have my contact information on the slide, and also have my email connection if you guys have questions or concerns or things come up that you want to be able to interact with me about. So the bottom line is the relationship between vertigo, or true spinning, and migraines was actually talked about in the 2nd century with the ancient Greece. And so this is a very interesting description that was taken from the 2nd century by Atrius of Cappadocia. I'm going to say that really bad with my Utah accent. But basically, they have evidence of people talking about attacks of vertigo where the person wanted to avoid light and found relief in the dark. There was flying threads that floated before their eyes, and their eyes seemed to move to and fro. That is really, truly what very often a vestibular migraine can be. But we went, you know, so it's been on and off in the literature the last 150 years, so we skip ahead a few centuries. But really the term vestibular migraine didn't get termed till the 1999. And it wasn't until 2012, relatively recent in medical terms, that there was even a consensus that was put together in the Intermountain community. And then in 2013, it actually was given its own diagnosis code. So in medicine, whenever something's been given its own diagnosis code, then really therapies can start to advance. There's a more consensus as to what's going on with it. How do we diagnose it? How do we treat it? And so that was kind of a big deal when the official international classification came out concerning this. And what I want to show you, this was this video that I'm going to show you right here is a patient who described that he would get these spinning episodes. They last for maybe 5 to 10 minutes. One of them came on in a car that he was in, and so he grabbed his cell phone and took a picture of his eyes. He reports that 10 minutes later he'll get a really bad headache, and he gets really light and sound sensitive while it happens. So I don't know whether our light will let you do this, but I'm gonna let this run, and I want you to notice that if there's something kind of spontaneous or kind of odd about what his eyes are doing. Do you see a rhythmical jerking that's happening in the eyes? There's kind of a bouncing that's happening, and it's not because he's looking at anything. He can't stop that. And I don't know if you can appreciate that, but the eyes are actually kind of bouncing in place. And at that moment, he says, the world's spinning. The world feels like it's spinning, and then that will stop, just spontaneously go away, and then he'll get a headache. And so that's a very common thing that we often see with these patients. A common scenario that I see in the clinic is a patient comes to me and said, you know, I've been having migraines since I was a teenager, they went away, and now all of a sudden I'm having these weird dizzy spells. So we have this history that they had migraines in the past, and I don't know any of you guys in the room, but you've noticed that your migraine can shift. Like it went from being a pain here or a stabby thing here to something over here to migraines can shift, the quality and the character can shift. And so we know that migraines can do these amazing, amazing things. And so it represents a huge spectrum of disability, a huge spectrum of complaints, disability, and we think that about 1 to 3% of the population is experiencing this true, what we call vestibular migraine, or a dizzy migraine. So instead of a migraine being something that hurts, it's something that spins. And It's hugely female, unfortunately, so we believe that's because of the hormonal influences and different things like that, but that doesn't mean that the men don't get associated with it as well. But, and doctors would call this the most common reason, most common neurologic reason to have vertigo. Now, most common inner ear would be a different thing, but the most common neurologic reason, and believe it or not, there was this really amazing article that was just published in 2019 by Bay. And vestibular migraine was put in an article called The Disease of the Year. Vestibular migraine in the Journal of Neurology and Ophthalmology was just touted as the disease of the year. So isn't that cool? You guys get the disease of the year to be able to talk about. So it can be a very difficult thing historically to kind of sort out and rule out, and so that's where medicine is really working. Can we do a better job identifying when is it migraine, when is it inner ear? And if we can do that, we can perhaps provide much better treatment than what we've been able to do before. So you guys have all experienced this in the room, but a migraine truly is this, what I would call a tsunami storm. It's a cortical tsunami storm where your brain goes through a series of what they call neurovascular depolarization, all this stuff. Your electronic system in your brain goes kind of haywire. And there's a whole bunch of consequences that can happen with that, and we absolutely know that it has fairly strong genetic vulnerabilities. And so some people would say we can blame your grandmother on this. Not that we want to blame grandmother, because grandmother makes great cookies and stuff like that, but sometimes it's on the maternal line more than it is on the paternal line. We know that these things can have multiple triggers, so they can have hormonal. So women, that's one of the reasons for why women suffer from this the most. And it seems that migraines don't like change. So migraines very often come on when women get their period. They can fluctuate with periods, and then they can also come on again when we go into menopause. So it's not just that they don't want the hormones, but they just don't like change. And they also don't like change in the amount of stress, the amount of sleeping. They don't like change, and so that's things that can actually lead to some of the treatment that we're going to talk about a little later. So there's multiple triggers. If your neck, this cervicogenic means neck. So is your neck having problems? We know that that can trigger it. Emotion, exercise, different things like that. So the problem is that we know that migraine can affect the centers in the brain. So it's well recognized that you can take someone in the middle of migraine that tells you they're seeing spotty lights going across their visual field, and a very sophisticated PET scan, or something that can actually look at the part of your brain that looks at vision. It can watch this going across your brain just like the person can watch it going across their visual field. So this is very neurochemical. It's very neurochemical, very defined, and it's your brain reacting to kind of a cascade of events. And so that's why a lot of the treatment has to deal with, could we give the brain something it wants? Can we give it some more serotonin? Can we give it some more what we call norepinephrine? Can we figure out what thing do we need to bathe this beautiful brain in to help it so it doesn't go into that storm? But what's been delineated in the last little bit was, so it affects nerves and blood flow, so we can get what they call dilation, which can cause a lot of pain in tissues. But what's very interesting is it can also cause problems in specific tissues of the inner ear. And this is where the vestibular or the dizzy headache or the dizzy migraine comes from. And so they actually know, believe it or not, how to give a rat a migraine. They mess with its neurochemistry and give it a trigger, and then they analyze where this rat has a problem. And we can very much put these rats on a pedestal for helping us understand where this comes from. But they've actually noted that the eardrum can swell, so you can feel like you have ear pain. They've noticed that there's swelling in the part of the ear for hearing. So you can get ringing in your ears, you can get what feels like you're losing hearing, but yet you go to the hearing doctor and he says, no, your hearing is fine. Your hearing is fine. And the nerves leading from the inner ear that go from balance. So in other words, you can get a vertigo attack. So you can have some hearing sequelae, you can have some dizziness sequelae, and it's all because of where is this migraine impacting? And what is the consequence of where that migraine is impacting? If that migraine is impacting the visual part of your cortex, then you might see some visual distortions. If that migraine's impacting where a lot of your pain and temperature, then you might get pain and the traditional things. So that we also know that from research. But what we know for certain, and you guys in this room can probably attest to this better than anyone else, it causes major havoc with what we call your sensory cortexes. So your sensory cortexes are your vision, your hearing, and your inner ear for motion. So in other words, when you get a migraine, what do you guys like to do? Do you want to go in bright sunlight? No, where do you want to go? Dark room, close the shades. Do you want someone singing loudly next to you? Usually not, usually not. So sounds seem distorted, lights seem distorted, and along with that, movements can feel distorted. So they literally know that at the time you're having a migraine, these cortexes that process your senses, your vision, your hearing, your motion, are kind of what they call on fire. They're hyperly active, and what's interesting is not only do they go on fire, but they can stay on fire for weeks to months and gradually get better. So you can have your migraine event, and then it can take kind of a long time for everything to calm down. I kind of tell my patients it's kind of like something lit a fire. The fire went out, but those embers, those coals, they can stay hot for a long time. So it causes a shift in the system. And so we know that people with even a remote, even if you've only had 1 or 2 migraines in your life, your brain is different. Your brain is more sensitive. Your brain needs to be taken care of in a different way than someone else. And so we know about that, and we know that the dizziness related to that can be just like the headache spells. So headaches can range from a kind of funky little visual thing I had to I was in bed for the whole weekend to I went to the emergency room because I thought I was having a stroke. So just like the spells of the headache, they can be, the dizzy spell can be seconds to minutes. The dizzy spell could be minutes to hours, like a typical headache, or it could be a disabling episode that truly does take you to the emergency room. That's hours to days. And this tendency for all these different timing can make it difficult, because in the dizzy world, we very often categorize things by whether they're lasting seconds to minutes, minutes to hours, or hours to days. And you've got this migraine that can mimic all of it across the whole spectrum. So it makes it even more important that we get to specialists in order to kind of tether this out and get this taken care of. So I've mentioned the word auras, and perhaps you guys in this room who have migraines maybe already know this term, but sometimes I didn't want to assume. So aura is kind of a transient neurologic symptom. So most common, I get this sparkly rainbow thing that's in my visual field, or I get a black hole, or I get a white hole. I suddenly can't see something. I have a friend who's an organist, and she goes, I just pray I don't get a migraine when I'm in the middle of playing in church, because all at once I'll have a black spot in the middle of my music that I can't see. So those are auras. They can proceed before the headache, during, or after. They can be in isolation. They're most often visual, but they can be a lot of different things, and dizziness can be an aura. They used to think that dizziness could only be an aura. We know now that the vestibular migraine can take over the whole sequelae, but dizziness can also be an aura that can be developed. So it used to be, so 5 to 10 years ago, if you said the word vestibular migraine, people would look at it and you go, oh, what is that? Because there really was no standardized, they said it, maybe it's called migraine-associated dizziness, maybe migraine-related dizziness. Vertiginous migraine started to come out. Atypical migraine is a common one that I still hear some people do. Migraine equivalent. And in children, sometimes there's something called benign paroxysmal vertigo of childhood that we'll look at. But we know now that we can actually call it, since 2013, vestibular migraine. And if you go to a neurologist who diagnoses this, they will have very set criteria that they'll need to hear from you in order to diagnose it. So you will have needed to have had at least 5 episodes that you had migraine features that kept you in bed. They were moderate to severe, not just, I had a headache, but I went to work anyway. It was, I had a headache and I was in bed, I could not do anything. Have a previous history of migraine is also important in this diagnosis. And then while you're having this vertigo or dizzy event, you've got to have, do you have a headache that's one-sided pulsating? Do you have sound sensitivity? Light sensitivity? Do you get auras? And with all migraines, we have to make sure that it's not something else. So the neurologist's job, the ED's job, is to make sure there's not the big bad uglies, to make sure it's not seizures, stroke, anything like that. And a migraine is talented enough to make a doctor wonder. And so that's why very often patients do need to go to the emergency room to try to figure this out, and that's where some of our patients come from. So some other symptoms that we'll see could be transient sound problems, nausea, vomiting, prostration. Now I think probably all of you guys in this room probably know this term, but you don't know what it's called. Prostration is this extreme exhaustion. Extreme exhaustion. I mean, you feel like you've been hit by a Mack truck, man. You are laid flat. You can't do anything. So you didn't know that, but you know what prostration is. Motion sickness. Now, we'll talk about this later, but motion sickness has a very strong correlation with migraine, vestibular migraine. So what can you experience if you're having a vestibular migraine? You can have spontaneous vertigo, which means that just comes out of the blue. I was sitting there and all at once I started to spin. Or you could have positional vertigo, meaning it didn't happen until I laid down, rolled over, looked up, bent over. You can have visually induced vertigo, meaning you went into some big visually complex world, which we live in a huge ones nowadays. Half the films nowadays are massively visually complex. You sit on the front row of that and you could swear you're like in the car with people who are doing a car chase. Head motion induced dizziness or vertigo, so just when you try to move your head. And you can also get disturbed spatial orientation. So you go to walk into a room and you go, why do I feel so weird and why do I feel like I need to touch this table? And so that can be common as well. So, and what we also know is migraine has a lot of different associations. So we know there's something called Meniere's disease. So there's a number of patients out there that initially thought they were initially told they have Meniere's disease, and it's actually migraine, or they actually have both of them at one. They're both probably the world's hardest differential diagnosis, is what doctors like to call it, where it's hard to tell the difference between the two. And we have some people who we have to track them for 1 to 2 years to really figure out, is it Meniere's, which is an ear-based problem, or is it migraine, which is a brain-based problem? We know BPPV, or that crystal problem that we were talking about before we started the lecture, where a crystal in your inner ear can get out of place, and you get this strong vertigo when you lay down in bed, look up, bend over to pick something up. It usually lasts seconds to minutes, always positionally provoked. So we have strong associations. We know people with migraine have an increased risk for that. We also feel that migraine can mimic some of the same symptoms as the crystal problem, or what we call BPPV, stands for benign paroxysmal positional vertigo, BPPV. And then motion sickness. We know that people with migraine, 30 to 70% of people with migraine, and maybe in this room, how many of you in this room have a tendency or a vulnerability for motion sickness? Yeah. It can be very, very, almost what medicine likes to call pathognomonic. I mean, it's something that goes with people that are having dizzy spells because of migraine. Because the normal population is probably 5 to 10% of people that can have motion sickness. But in a migraine population, it's hugely different. And then anxiety and depression, which we'll talk about. What is the link between anxiety and depression that can come? And they theorize that, actually not theorize, they actually have shown that there can be a 65% incidence of definable anxiety because of the migraine. And I'll talk about that in just a few slides. There's actually a neurogenic reason for why that goes together. And so what you have to realize is the same neurologic pathway, the same neurochemistry that your brain uses to create pain, i.e. a migraine, is the same pathway it uses to create anxiety. So if you're having a neurochemical problem that's predisposing a headache or a migraine, you could also be firing similar pathways that lead to anxiety. And not only that, we know that the same neurochemistry can also start involving the inner ear. So you can get a defined event that happens for minutes to hours. You can start getting motion sickness that you might have had some, but now it's getting really bad. And you start getting really sensitive to movement. So vestibular, that's inner ear hypersensitivity, that's really sensitive to movements. And you can start getting anxiety, and you can start developing a balance disorder. Those are all coming from the same thing, the vestibular migraine. I told that to a patient once, and she looked at me, and she started to cry. She goes, oh my gosh, I thought I was going crazy. I'm having these dizzy events, and I was just feeling so anxious, and I just thought it was me not being strong enough with the dizzy events. It's like, no, there's neurochemicals going on with this, and so as we calm down the migraine part, we'll also calm down the anxiety part. Certainly understanding about it is also powerful as well. But so there's these kind of 4 associated features that we see when someone has a vestibular migraine. In kiddos, there is actually something called benign paroxysmal vertigo of childhood, which is actually something that happens in people who are kiddos who are 1 to 4 years old, up to maybe 10 years old, and they get distinct spells of dizziness. They don't talk about a headache. distinct spells of dizziness, and then they just kind of goes away. We believe that is a migraine variant, meaning it's being caused by migraine. And there's actually something also called abdominal migraines, where people get abdominal pain that comes and goes. So these are kiddo pediatric presentations that we can also see with this. So how does someone diagnose vestibular migraine? It's going to be based on, the past history. What is the quality of your headaches? What is the timing of your spells? And during these dizzy spells, do you get headache features? Just like when you got a headache, you wanted to go in a dark room. When you get the dizzy spell, you want to go in a dark room. Just like when you got your headache, you felt like your mom was yelling at you when she was really talking at her normal level of speech, just because your sounds were so sensitive, and you didn't want to move. I have a friend who gets migraines, and he's able to use Coke or caffeine to help abort them, but he sits there when the migraine comes on and debates, should I get up and move to the fridge to get the Coke, or do I sit here and not move because I don't want to move? So they look for that, and of course a doctor has to see you to rule out other causes. They have to rule out, is there anything else that's going on that needs to be addressed, and any medication. You have to also rule out inner ear dysfunctions, so a fair amount of you will also have to be sent to ear, nose, and throat type testing, where they can take a look at what's going on with the ear. They want to look for visual phenomenon, because visual phenomenon can support this diagnosis. So you get a dizzy spell and you saw sparkly lights, that's something that the inner ear can't do. And so basically they're looking to build a case for this. Family history, does your grandmother, does your mother, does your father, does your sister? Usually what they call first or second degree relatives. So it doesn't have to be a distant aunt once removed, but in your family history, moms, kids, grandparents, is there a vulnerability for this? Dr. Degree, the wonderful, wonderful physician from the University of Utah, I believe she's been quoted as saying, either you have a migraine brain or you don't. Either you have this vulnerability, and it's really, that somebody has this vulnerability is really something in there. It's a genetic vulnerability, and to be appreciated. It's not just that you're just not tough enough with the migraine. It's like, this is its own thing, and you have to learn how to take care of it in a very different way. We look for history of motion sickness, because if someone's motion sick, that also attests to the fact they might have a migraine vulnerability. We look for light and sound sensitivity, and by that, we're looking for abnormal sensitivities, meaning, any of us, when we walk out into the bright sunlight, can feel a little light sensitive. But a migraine patient can be in normal levels of light and feel like, holy cow, why on earth is that light so bright? And their spouse can be talking to them at a very normal level of speech and go, will you stop yelling at me? Will you stop yelling at me? So normal levels of sound, normal levels of light, and it can cause some very distinct dysfunction and disorder. So we know that there can be a number of triggers. So another thing that I look for as a clinician is this person coming to me describing spells of dizziness that happened after they drank some red wine, a spell of dizziness that happened after they overexerted themselves when they hadn't been exercising, or they got dehydrated, or a spell of dizziness that came on with their menstrual cycle. So we actually look for this as actually helpful diagnostic information. So often I'll be saying, patient is experiencing dizziness spells that goes with unique migraine triggers. So stress, hormones, skipping meals, barometric pressure. We do know that migraine patients end up in the EDs more often during a barometric pressure shift. Sleep disturbances, where you stayed up all night. One of my patients was a business executive that decided to not train for a half marathon, but did it anyway. Got very dehydrated. We went down to St. George, did the half marathon down in St. George, ran it, got very dehydrated, jumped on a plane flight right after that, didn't sleep very well, got a big glass of red wine. This man had to be carried off the plane in a massive event that he had never experienced. He basically violated every rule of thumb for possible migraine. Overexerted, deconditioned, sleep deprivation, and red wine. So you add it all together, and that's just like what they call a migraine mixer. Something that's going to, potentially trigger these things. So, so we know that this can go along with that. We know that if this patient's having a migraine-based vestibular problem or a dizziness problem, it should have some kind of episodic nature to it. Now, you can have some symptoms that last between. a balance problem, some motion sensitivity, but you'll have distinct periods where you are really bad. So we watch for things to be episodic, and they can be true vertigo attacks. Gait and disorder stuff can persist between that. They'll have a definable balance deficit that's going on, so they just don't feel as secure, they don't feel as confident. Head and motion intolerance, and it can be very acutely, can be very exquisite, and then it starts getting better. And then they can have positional vertigo that sometimes is related to the crystal. That's the BPV, that's the crystal thing, but sometimes it's not. And so it has to be differentiated as to what's going on with that. And so this is an example of a patient actually that went into a physician when she was in the middle of a migraine, and they're gonna put her down in a diagnostic test, and what happens in these diagnostic tests is, oh, this might play. So they're gonna lay her down, and when she was sitting, her eye didn't do anything funky, but when she laid down, all at once her eyes start moving rhythmically. The quality of that rhythmical motion, what it looks like, how long it lasts, whether she's dizzy or not, means a lot to a clinician. And then what's the difference between one side and the other side? And is there different qualities to that? And this one here is actually a quality of something that looks a little bit like a crystal. It's spinning, it came on suddenly, and then it went away. Where the first one you looked at, where it was just going sideways, and she said, oh, it wasn't too bad. So there's actually a fine art. So a clinician who really understands how to differentiate that can take a look at, they can put these goggles on, they can put you through different tests and try to look, is this migraine, or is this possibly a crystal? And a crystal is something that, again, can be repositioned and can have 1 to 3 treatments. We can take good care of you. So what do we do with treatment? So I tell my patients all the time that controlling the migraine. So even if you're having a vestibular migraine, a dizzy migraine, you still have to control just the way you did with the headache. So getting the headache under control is going to be powerful, powerful. But getting you to understand what you can and can't do, getting you to be educated, that's why things like this headache school are so vitally important, because you guys are the ones that are going to have to manage this. It's a very delicate dance that my migraine patients play in figuring out, how do I get this to go into remission? How do I get this to heal? And so education and treatment is going to be part of it. There was a book that was written in 2008. It's almost becoming out of date now, but it was a very comprehensive book called The Migraine Brain by Carol Bernstein, 2008. Doesn't really talk about the vestibular migraine, but has wonderful chapters talking about all the kind of alternative treatments, some of the pathophysiology. How do you go about even analyzing, what's going on, how many triggers you have, and things like that. You would think that understanding what triggers you could be just a simple, straightforward thing, but often not. Often it takes some detective work, analyzing, what was my routine? What kind of things happened before, within 2 hours, within a day of my event? Is there things that can be looked at? So certainly getting a resource, and your doctor, each doctor in this room probably has a different resource that they like to give. But I would absolutely advocate that you really understand what's going on with this pathophysiology of the migraine and what can happen with it. So what MDs or doctors can offer is they can actually offer potential medications that can be what they call abortive, meaning it can stop the attack. So a certain amount of migraineurs get enough of an aura or a warning, pre-drome stuff that they go, oh no, this doesn't feel very good. And they can actually take a medication. So in today's world, we have professional NFL players, professional tennis players who have active migraine, but because they have abortive meds, they can keep a full lifestyle. That was something that we couldn't have done 2 decades ago. But the fact that we have meds that can actually abort and stop the attack. And vestibular migraine is no different than traditional migraines. So they can actually, doctors have to take into account how often is it happening, how disabling is it. Not everyone's a candidate for these different medications, but they will be able to run you through. What I find important as a clinician is just to make sure that patients know. Did you know the doctors sometimes can use abortives, but you have to know what the bag of tricks is that comes with that and when is it indicated. They can sometimes give palliative, meaning it relieves the symptoms. Okay, I'm spinning, what do I do? When you get a headache, you take an aspirin. What if I do if I'm spinning? So what can I do? And there's a number of different drug classifications that different doctors use, and each doctor has a different combination based on the understanding of the literature that they have, the experience they've had with patients, the age of the patient. The age of the patient will vary as to which medications are most indicated. And usually it's very important for any headache person to understand that if you use over-the-counter medication too much, or any of these kind of abortive medications too often, that can actually make it so you get more headaches. And so, but your doctor will be able to talk to you about that as well. Just making sure that whatever you use is being used in a timely fashion for the correct dose. And so we know that that can actually lead, overutilizing of medication can lead to almost as many problems as underutilization of medication. So you'll need to work really carefully with your doctors on that. This is obviously way above everything we're going to talk about, but I want you to know that doctors have a lot of things that they could potentially try to help get your migraine under control. And these are what we call preventative migraine meds. These are medications that help to reestablish what we call vascular tone, or the blood flow tone in your body, that give the brain a certain neurochemical. And they're medications that were meant to be put on board and analyzed over months of time. So they're not like an abortive where you take it and everything goes away. They're something that help to rebalance the neurochemistry in your brain and make it so it's less likely so that you get it. And so there's literally antidepressant pills that they can use. There's vascular or beta blockers that they can use. Some of these medications have recently been shown, to not be as utilized. Anticonvulsants can actually be used because basically, again, they are trying to bathe the brain in a chemical the brain needs so it doesn't trigger that tsunami storm of the migraine. And Botox is also, if there's certain criteria that people have to use, they have to fail prior trials. But again, the main intent for this slide is just to make sure you know there's a number of medications, and your doctor is going to have to work with you closely, whether you're a candidate for having these and or which one would be the most appropriate one if you are a candidate. So, but what PTs, so I'm a PT, and so my love is to prescribe exercise, where doctors prescribe meds. So what we have to offer is something called conservative treatment. And conservative treatment is, I have to tell you, very, very powerful. It can take months to explore it, and you have to be very patient. My migraineurs usually have to use the three Ps, we call them: patience, persistence, and perseverance. But if you're willing to do that, there is a huge amount that can be gained from conservative treatment. And usually I try to kind of frame it. I had a beautiful kiddo named Kevin, who was 8 years old, and we diagnosed, he had a family history of migraines, was having these dizziness events. He got confirmed by his doctor that he was having vestibular migraine. And so I started my education to Kevin. I said, Kevin, do you realize that you have a Ferrari brain? And Kevin looked at me and said, what do you mean I have a Ferrari brain? You have this amazing brain that's capable of incredible things. But just like a Ferrari, you're gonna have to learn how to take care of it. And a Ferrari's, it's gonna be different. You wouldn't just leave a Ferrari parked out anywhere, and that means you may have to come home and get rest or pace. Where your friends are out playing all night long, you may have to come home and take a nap. You wouldn't put any kind of gas in a Ferrari. You might have to be very careful about how you eat, when you eat, not skipping meals. And so you just have to learn, this Ferrari of yours, this amazing brain that you have, is capable of amazing things, but you just have to learn how you take care of it. How do we take care of it? How do we nurture it? How do we give this brain what it wants? Is that a medicine? Is that an exercise? What do we need to give it so it can heal? So conservative treatment basically consists of making sure patients know what they can do to make a difference. So really educating them, and you guys being at this headache school today is one of that. And then what we know is that migraine frequency and severity has been known to change if people get better sleep, if they hydrate more appropriately, if they learn relaxation techniques, which I'm so excited for yoga. If we do vestibular rehab, which is kind of helping to cure, kind of help the side effects that have been given from the vestibular migraine, exercise. And I'm going to show you a very powerful study that showed the role of exercise. Neck treatments, activity, pacing. So I've had some patients who the main thing that they did was just give their brain some downtime. I had a patient who was a counselor at a school, very intense job. She had migraines. We didn't seem to be making a difference. She kept having problems. But we talked about pacing. We went through this thing where, if you just give your brain some downtime, maybe that will be enough so you don't keep having episodes. And so this beautiful patient, she went in and she told her secretary, okay, so I come to work at 8. At 10 o'clock, I want you to close my door, screen my calls for 10 minutes. And she would sit and relax, not do makeup work, not do her emails, just relax. And then at noon, instead of doing a lot of projects, she actually went out for a walk or listened to a tape, listened to some music. And then at 2 in the afternoon, she did the same thing. This woman totally changed. She figured out that her brain just needed a little bit more downtime, not this intense stuff that we all want to do. And because this can be powerful. And some of my mamas, it's a difference between whether their migraines get under control is a difference between whether they have a clean house, whether their migraines are under control. Because there's going to be a sacrifice as to when do we pace. Diet and diary analysis, so finding out what your triggers are and taking them on. So let's just dive into that a little bit. So again, you have to manage the headaches, so whatever your doctor is prescribing, and if it's a preventative medication, can you stick with it for the amount of time you need to for that trial to run? Because a preventative med sometimes can need 2 to 3 months to really know whether it's working or not. Can we as physical therapists advocate for all medical conservative treatment options, so educating my patients? Can you get a resource book like what we talked about? And the bottom line is medicine absolutely knows, and you guys need to know this. Migraines have a natural history of going into remissive periods. Meaning you can have migraines for 2 to 3 years and then they go away for 20. Migraine's natural history is that it will go away. It will go into remissive period. And what medicine's job is to help it coax it to that remissive period sooner. And so I get my patients to always be able to say the mantra, migraines can go into remission, migraine can go into remission. You can be in the middle of, a 1 to 2 year, what you feel like is just you've been in hell for 1 to 2 years. It's like migraines can go into remission. I just have to find out what my brain needs. But migraines can go into remission. And so we have to get them to do that. So can we nurture this sense that we can have this realistic expectation that if migraines are active, can we lessen the severity and frequency? And then can we move this migraine to a more remissive state, or where it wants to become quiet again? Migraines absolutely can become quiet and leave you alone. And what I really teach patients is this concept of lowering your threshold. So everyone in this room has a threshold with, if you violated certain things, you're going to trigger a migraine. You stayed up late, you skipped your breakfast, you had some coffee, and then you had an argument with your boss, boom, then everything falls apart. And some people's threshold's down here. All they have to do is look at a chocolate bar, boom, they're going into a migraine. And other people's is clear up here, like my previous case study who, he trained, ran a marathon, got dehydrated, skipped, had red wine, and then his threshold went. So, and what we know about migraine is you can raise that threshold. You can raise that vulnerability. The more you exercise, the more you move, you can decrease that vulnerability you have to elicit a migraine. And that's a really powerful thing for you all to know. So every time you take a drink of water when you weren't going to, you raise your threshold. You give yourself some what I call neuroprotection. When you sleep, we're going to stay up and do a deadline for 3 hours and instead you go to sleep. You're neuroprotecting your brain. When you go for a walk, when you were just going to veg out and watch a video, you're neuroprotecting your brain from migraine. So there's powerful things that are there. So looking for triggers, it does require some analysis, and this is an app, a cell phone app, that can be very helpful. It actually helps migraineurs track their migraines, because when you go to a neurologist, the neurologist says, so how many migraines have you had in the last 3 months? I don't remember. But if you have the Migraine Buddy, it will say you've had 5, they were triggered by this, they were associated, and it actually gives you prompts for when did you wake up? When did you go to sleep? And so it can, if you are an app-friendly person, now not everyone is an app-friendly person. If you're an app-friendly person, it's kind of a fun one to kind of explore, to look at, could better sleep, if I talk to my doctor about sleep, could that help me? Could making sure I get 8 cups a day? I have a friend, man, if she does not drink her 8 cups a day, she is going to be in a migraine within 3 days, okay? It's a powerful one. It's a powerful one. And then diet. We know that about 1/3 or 33% of patients have food triggers. Not everyone does, but if you have them, it's a very powerful thing to know about. Very powerful thing to know about. And so basically, most of the diets that are out there, there's a number of them out there. Not all of them have been proved at a very high level of scrutiny, but they very often have the similar thing where they're trying to decrease your exposure to things called tyramine. And it's basically, that's a natural, tyramine is a natural element in certain foods. It's not a preservative or something. It's a natural element that tends to be in things that are more aged or preserved. And it can alter more vascular tone, and so we try to limit that. You don't want to skip meals, and you want to eat at a regular time. The main big ones, red wine, so anything that's aged in a barrel tends to have a lot of tyramine in it. Caffeine in any form, now we'll talk about caffeine can be an abortive, but caffeine in any form can do it. Packaged or preserved meats, things that are barbecued, nitrates, tyramine. Hard cheeses, peanut butter can even be a trigger. And so it needs to be analyzed and looked at, and the goal is to go off possible, even for a 2 to 3 month period, or at least look at it. And what's interesting is if you're exercising, sleeping, and stress managing and pacing, you could maybe violate the food stuff. But if you're under stress, you haven't been sleeping well, you're on a deadline, then that chocolate bar might be the thing that just puts you over the edge. So it can be the intensity of things. So stress management, we know aerobic fitness, huge, huge, huge. Huge, 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 and it does not have to be intense. Most people think of aerobic fitness as I'm out there sweating at a high exertion level. It's like, no, you just get your heart rate up 10 points and do that 4 times a week, 5 times a week. And you can bathe your brain in some more oxygen, and you can release the neurochemistry that can trigger a migraine. It burns off cortisol and some of the adrenaline stuff that can sometimes screw with whether you're gonna get a migraine or not. Relaxation programs, highly indicated, and a number of headache programs incorporate yoga, just like you guys. I'm so psyched. We get to do some yoga after this. So yeah, and it's often not because you don't do yoga because you're trying to master down-facing dog. It's because there really is a power, the mind-body connection, there's a power there to understand ourselves, to understand and connect at a deeper level, and understand our tension and things like that. So this is a study I'm not going to go over. This was a Norwegian study in 2011 where they compared migraineurs, and one set they put on an exercise program, 40 minutes, 3 times a week. One was put on medication, Topamax, which is a high dose preventative med, and the other group did relaxation. And they were taught it. And what they found was the relaxation group improved by 46%, the exercise group by 48%, the medication group 52%. What if we could combine these two things together? That's pretty powerful. Powerful in comparison with a known medication that's known to decrease severity and frequency of medication. So getting you to exercise, looking at stopping smoking. Estrogen level with kids sometimes has to be looked at. Multivitamins can sometimes help. Photosensitivity can be an issue, and having certain kinds of glasses is sometimes indicated. And the Moran Eye Center here at the university is a leading authority on this. They actually know that rose-tinted glasses kind of filter subliminal light and can actually decrease the excitation of the visual cortex. So, but what about vestibular rehab? What can we do? We know that we can help you improve your balance. There's different exercises that can help you feel where your center is. What I often tell my patients who have migraines is there's a difference between an actual balance deficit, meaning you had an inner ear problem, you had a stroke. Migraine causes this perceptual distortion, which a therapist can help you regain your confidence again, because all of your balance pathways are still there. It's just the brain is going, I'm just not sure about them. It's not sure about them, but the pathways are there. So this perceived versus actual, and we really can get people to normalize their ability for single leg, heel toe, standing on foam, different things like that. We can get people to normalize, we can test for BPPV, this crystal problem, treat it and get that out of the picture. And if that's not the problem, we can grade habituation, meaning if you're sensitive to head motions, believe it or not, the more you do them, the less you can be sensitive. But what people do with dizziness very often is like, oh my gosh, I'm so sensitive to dizziness, I'm gonna stop moving. When actually the best thing you could do is, well, I can't do a lot of that, but I should do at least 3 or 5 reps. So a therapist can actually help you select exercises to help you expose you to the motions that will help you get better. And then all this gets integrated into balance, so you're doing all of it at once. You're doing things that require head motions. At the same time, you're standing on a piece of foam. Maybe your eyes are closed and different things like that. And usually all of it is going to be incorporated into a relaxation program as well. There's also a third area called visual motion. So anyone who's had a migraine long enough sometimes develops what we call a visual sensitivity. They don't like to go in grocery stores. Their computer screens seem really busy, even looking at their phone. If someone's flipping through phones on an iPhone, they'll go, oh, God, get that away from me. I don't want to look at that. We cannot work on this if you're in the middle of an unmanaged migraine. But if you've stabilized your migraines, you're improving your motion tolerance, you're doing some activity, we can actually have a whole nother area where we can actually expose people to different environments. We can put things on that are actually, actually moving, and we can actually get people to start finding them less and less symptomatic. I can't get this to move. Because basically someone who's visually motion sensitive would not want to go, this is the Venetian in Las Vegas. If you're visually motion sensitive, you would not want to come into this place. Everything's busy, there's loud noises, there's people walking by you. And so we can actually do things where we prescribe umbrella twisting drills, watching things being catched and thrown. We have a disco ball in one of our offices at our clinic. So we literally can take you. This is one of the machines we have at our clinic where we can actually take someone. This is a snowboarder that developed headaches after her snowboarding accident, and we were trying to get her to desensitize to visual motion and things moving around her. So she's doing a balance task at the same time lines are moving. Or we could actually put her in a virtual grocery store. So there's actually things that we can actually do with that. We can tap into computer and phone apps, just different things. The bottom line is, what makes you slightly dizzy can heal you. So instead of avoiding it, actually gradually exposing yourself to it in a very structured way can actually help you get better. So I've had people playing computer games, finding the letter that's not right. I've had people playing different games where they have to find things and look at things, and there's a number of them out there. And I've even prescribed people going to grocery stores. Okay, I want you to go when it's not very busy, when it's in the morning, you feel good, and you go for 10 minutes. And then we gradually build that. So we literally get them back into things. So, I've prescribed YouTube scenes before as well, dosing to smaller and larger scenes. But the bottom line is, vestibular migraine can be managed. It can be improved. If the severe vertiginous spells usually need medication and conservative treatment, but we can lessen severity and frequency by 50% over 3 to 6 months. If it is the crystal problem, 1 to 3 treatments. If you have become motion sensitive, we can lessen severity and frequency over months. If you have motion sickness, if you just get your migraine under control, the motion sickness is going to get better. And there might be some medications or habituation we can do. Instability, we can train you. And substantial gains over even 3 to 6 sessions to get people to get back to their balance. And this concept of space and motion discomfort, can we get you back into grocery stores, if that's an issue? Not everyone has that, but that's sometimes an issue. So the bottom line is that there's lots that you guys can do. There's lots that can be done in therapy. Vestibular migraine is an entity that can be identified. It can be very effectively treated. And so I will just kind of open the floor up to any questions for me on all of that. And I do know that the slides, is it right, the slides are going to be posted? So all the slides that I showed are actually being put on is it a website?
It's on YouTube.
It's on YouTube. So this whole presentation will be on YouTube, so you can access that again. My email is on the first slide, so if you have individual questions that you didn't want to ask by yourself, please let me know with that. Are there any burning questions that are coming up? Very cool. Yes?
Would seasonal allergies have any effect on?
Seasonal allergies. I don't know of any. We do know BPPV can have seasonal fluctuations. So the crystal problem by itself can. We know that seasonally barometric pressure shifts can be an issue. So the more the barometric pressure shifts are going. Allergies by themselves, I do not know of any connection with like an allergy type thing, but so probably the barometric pressure shifts, the more stable our weather is, the more migraines like that. So if we're going through lots of fluctuations and stuff, then that could be more of a trigger. Not that I want any of you ever tracking barometric pressure levels. Don't do it. Don't do it. So yeah. Any other questions? Yeah.
For the dizziness, is that something that has to be before the headache? Can it happen during, sometime in the course of it?
So the dizziness by itself, so the vertigo dizziness part of it can be an aura, so it could happen before. It can be the actual event. So you can have, I don't know what it was you had, but you could have an hour event where you're spinning and it is truly the migraine that's doing it, the neurochemistry in the brain. So the dizziness can come before, it can come during, or it can persist after, where a traditional migraine actually just shifted your balance, so you're kind of more visually sensitive, you're feeling kind of off balance and stuff like that, and that can last for weeks to months after a single migraine event. So we can have things that kind of chronic after what I would call migraine-associated dizziness versus the true vestibular migraine, which is a true dizziness, vertigo, spinning event. So all of the above, all of the above.
Can you have the vestibular migraine without the actual headache?
Absolutely, good question, yes. Yes, a migraine is not a headache. Isn't that a crazy thing? People will look at you and say, you are stupid. It's like, a migraine is a neurochemical event, and wherever it happens is what you get. If it's in the occipital lobe, you get visual stuff. If it's in the temporal area, more towards the brainstem, you can get a true vestibular event, a spinning event. So depending on where it is, and you can absolutely have a vestibular migraine without a headache. Excellent question, excellent question.
So can you have a vestibular migraine without being really dizzy? Or is dizzy like the integral part of it?
So can you have a vestibular event without being dizzy? Not from a migraine, so not from a migraine. There would be certain medications that could cause an inner ear problem that can make you have, but no, not in this world. So with you can have, migraine can cause traditional migraine. And what I do know is that even a traditional migraine, just a migraine where you get a temporal throbbing, you go in bed 3 to 4 hours, and then after that, it's like you're motion sick, you don't want to move your head as much, your balance feels off. So you can have migraine-associated dizziness that happens after a traditional migraine, which is a normal kind of pain, throbby migraine that you think of as a migraine. But yeah, usually if it's a vestibular migraine, then you have the spinning vertigo that goes with it.
And so if someone's experiencing this, what would you suggest, like the first step to getting a diagnosis or just getting on the right track?
Yeah, it would be getting to a specialist, and that, I know you mentioned before.
Specialist.
So a neurologist usually, a doctor that specializes in headaches, because not all neurologists specialize in headaches. And most of them are actually getting to where they'll put their shingle out, say, I am a specialist in migraines. So in the Intermountain healthcare system, there's certain docs who do this. In the University of Utah system, there's certain docs that do this. And I would definitely go to somebody who it is their specialty practice. Yeah, and that can be hard, and then they have waiting lists, which make us sad. But do be assertive and get on their waiting list and call. The squeaky wheel does get in faster, I promise. Any others?
I have a question.
Mm-hmm.
So on the alcohol, is there a difference between red wine and white wine?
There is actually. So there's something when things are aged in a barrel, and someone has told me that actually the type of preservatives that wine corporations in the United States have to put into their wine is much more provocative than if you got wine from France. It has less preservatives in it. But there is something about the red wine that is much worse.
Any correlation between that and resveratrol, because they take that component, or is it the actual aging process of the wine?
I thought it was the aging in the barrel, but I could be not know as much as I should on that. It's the aged in the barrel, it's the amount of tyramine that goes into it, and the amount of preservatives that get put in it that seem to be the factor, but I'm not sure I'm the full expert on that.
And is there anything you can do differently if it's a hormonal imbalance with the vestibular migraine than if it's caused by something? Hormonally they can actually work with you on putting you on birth control type things can actually be explored, where they can do long-term birth control to try to keep the estrogen levels at a steady state, and that can be very powerful for a number of patients. So that can be explored. Anything else, or it's time to get to yoga? Awesome. Well, thank you very, very much, and I hope you all reach out to me if you have questions or concerns or anything else from this, and I hope this will ripple out with benefits to the world, right? So thank you very much. Thank you.